first thing that we did was with the childhood study group out of Chapel Hill, and we looked at how well we were doing our well child care, and were we hitting all the elements consistently and all the time. And we found that we weren't, even though we knew we were doing a good job. And that was the thing that, that really started us into looking at this whole issue of quality. One of the first things we looked at was asthma and how, as a practice, you can improve quality if you implement correctly the national guidelines for asthma care. In the year prior to our initiatives in asthma, there had been over 700 pediatric visits to our local emergency room with the diagnosis of asthma. The year following our initiative, there were less than 200. That showed us all that, wow, if we can make this kind of difference doing this kind of quality initiative, what else can we do?
I always, kept hearing comments saying, well, I mean, with the homeless, you provide acute care, you provide triage type of care, and it's really very difficult to manage, chronic diseases with them, very difficult to make an impact on the long term while managing a very transient population with the homeless population. And I actually really took that as a challenge. I said, you know what, yes, I can do it. Yes, we can make a difference. We can improve outcomes in our homeless population. That was the most important step. The next most important step was really to get the buy-in of the staff and the healthcare for the homeless program. And it was a shift in mentality for the program.
We started out as a very small 4-person group that had the vision of growing and developing a integrated cancer center in our community. What we know typically in oncology is that it's pretty much like other specialties, and that is people have to go to different places for different services. What we wanted to do was to create a fully integrated service, a fully integrated system and process. All of this is created for patient flow. Radiation oncology, medical oncology, laboratory, diagnostic imaging, and support services. The beauty of this is the integrated component of it, and it's got to be based around quality.
The first step in creating a clinical quality program in our healthcare for the homeless was to actually look at the Disparity Collaborative, take the chronic disease model by Ed Wagner, and try to implement it in that program. We've tried different options with data collection. We've started from using the tool that the Bureau of Primary Health Care had out there for the community health centers to use, to developing our own tool, then to kind of partnering with with our partner hospital and our partner laboratory to kind of get that data electronically from them and be able to work around it and be able to generate reports back, to the provider teams. And I think that has been very, very helpful.
The Division of Medical Assistance, which oversees the Medicaid program, understood the significance of improving quality and the cost savings that would come to them. And they underwrote our tuition to many of these collaborative efforts where we could go and get the training and learn the techniques. Had an opportunity to participate in a collaborative to further increase the quality of care for ADHD. One of the things that I gained significantly in my care of my patients was a greater understanding of the importance of the behavior modification part and the significant impact that that can have. The collaborative allowed me to improve that aspect of how I was managing my patients, and I've seen significant success.
Change is very difficult. Change is very difficult in medicine, especially because of the deep grooves of tradition that exist in medicine, and deep grooves sometimes are hard to climb out of. What we try to do is to create a paradigm of why we do things, rather than saying we want to start an electronic medical record system in our practice. We want to give the reason why. So when we're actually able to demonstrate the outcomes of what we're measuring and show those outcomes to the people that are putting in that information, it makes adoptions much easier.
when you have a nurse who's been, you know, a nurse out there in the community under the bridges and in the shelters and in soup kitchens, and you ask that nurse to kind of try to collect data and will analyze the data. I mean, that needs a whole educational process. That to me was the biggest challenge. When we went system-wide, there was more and more resistance that I started identifying that I had to deal with. Then sometimes you gotta get to a point where you had to make, you know, a major decision and a hard decision and let people go, which is something, you know, nobody likes to do. But if you're committed to really making an improvement and making an impact, you really want people who are on board. I think to get improved outcomes, you really need to create systems in place to make it easy for providers to do the right thing. And by creating, you know, types of flow sheets for diabetes, we have a flow sheet for diabetes. It makes the life of the provider easier to make sure that the patient is receiving standard of care. We've done the same thing with asthma by implementing our asthma action plan and the chart. And then really we worked individually with those patients and get them standard of care.
When we were developing our acute care sheet, that went through multiple iterations before we got to the final one that we now send to the printer. And that was done using this cycle of improvement until you reach the goal that you're looking for.
All of our processes are recorded electronically on a format that has the ability to capture data. And when data is captured, then it's reportable.
Do we have any idea when we're going to reduce scans?
The first query we did, we found we actually treated women with lung cancer less aggressively than we did men. And so we came back and discussed that and changed our behavior altogether. It was a real eye-opening experience that has created actionable knowledge. It was not something we wanted to see, but it was something that was very important for our patients. Our goal with electronic information management is knowledge. It's knowledge that changes behavior.
Before our Open Access Collaborative, our wait times were awful, and we were even developing a reputation within the community. The truest sense of open access means that you can be seen by the physician you would like to be seen by on the day you need to be seen. And traditionally that's been sort of the hallmark of pediatrics.
Clinical, what we do in the room, I don't think that's changed by open access. I think what's greatly changed is the fact that patients are willing to come to the appointment and that they're not upset because they've been waiting forever by the time you finally get in the room. It just makes it much more pleasurable and that lets you practice medicine better.
The fourth quarter of 2004 was the first quarter that we had no disparity in diabetes outcomes among our Caucasians, African Americans, and Hispanics. And this was a big reason for us to celebrate.
18.5% of our patient population here at Crusader is Hispanic. We pretty much know every single one of our patients that comes through the door by name. We know what medicines they're on.
The role of eliminating that, that language barrier has been key in improving outcomes in our non-English speaking patients.
We have a very open communication system here where we have staff meetings regularly, and we have our quality council. And our quality council measures everything from chemotherapy regimens and protocols to job descriptions.
We have a representative from a lot of the different disciplines within our own practice, and we get together and talk about issues that affect patient care, and we talk about issues from the standpoint of trying always to do it better the next time. We do all of the review of our unusual occurrence reports, any new initiatives that we have, and try to come up with the most efficient and effective ways to implement things.
Just by having everybody thinking quality improvement, clinical improvement, just using your focus and your energy to improve quality, by creating that type of culture, it makes it a lot easier to get the right thing done.
We took our cycle time from an average of 80 minutes, and that's average, and that's not something that you'd be very proud to put out there, but we took it from 80 minutes down to just over 30 minutes.
Just come on down this way and we'll get you in a room.
It also dramatically improved our bottom line. If you see more patients and you do it more efficiently, the patients are more satisfied. And that's one of the things that makes all of these initiatives important to us, because we've seen that we can make significant changes, and it's good stuff.
When we started in year 2000, our average hemoglobin A1C for the clinic was 9.4. At that time, we had 1,300 diabetic. In 2004, we had 2,150 diabetic with an average hemoglobin A1C of 7.6. You know, that is impact. I mean, when you see, if you know that with every drop in 1 percentage point in hemoglobin A1C, you reduce mortality and morbidity by 20%, having a drop of, you know, almost 2 percentage point, that's a tremendous impact on these people's lives. And I think that to me is very rewarding. That is very rewarding.
Since we started to employ all of our quality indicators and our quality mechanisms, it's changed everything for us. It's changed our attitude. It's changed our communication internally, because we are always looking for new ways of doing things. And people come to us all the time internally and say, why don't we measure this or that? And when it does, it's like always renewing.
I think you can do clinical quality work with no help at all, no resources at all, and just be smaller. And I really think that if you start small, you'll always get help, you know, along the way.
I love working with families who are struggling with a child who has attention deficit. They're failing in school and everybody's yelling at the kid and nobody knows what to do. And you sit down with that family and you spend some time helping them understand what it is, what you can do about it, what their options are, help the kid understand why those things are happening to them that they don't understand, and you see physically the changes that occur right there before your eyes, and they're excited about their successes and the things that you've been able to help them to do. It doesn't get any better than that.
This is the best of all times for me, because I know I'm doing something that's meaningful. I know I'm doing something that's measurable. We can make a change in our own practice, how we practice personally, every day in the quality of our care that we give our patients. It changes our lives. It does get us up in the morning.